Hello, my name is Jennifer Mitzman. I'm an associate professor of emergency medicine and pediatrics at The Ohio State University and recording this module on teaching on shift in emergency medicine for the Society in Academic Emergency Medicine Education Committee. Welcome to the final module in our 5-module series on teaching in the emergency department. In this module, we'll teach an often challenging skill, procedures. Unfortunately, these skills often have to be taught starting before a shift in order to lead to lasting learning. Here are the learning objectives for this module. We will describe different components of procedural skills and what a learner has to do to demonstrate competency in that skill. We will look at the classic adage of see one, do one, teach one, and how this can be ineffective for lasting learning. And we will look at 2 techniques for teaching procedural skills that you can use in the future. Procedures are a key component of emergency medicine practice. Learners are excited by doing procedures, but it's important to understand the level of knowledge prior to allowing a learner to do a procedure, particularly solo. In a busy emergency department, it can be challenging to spend time teaching a new procedure to a learner while balancing the other needs of the department. Utilizing a framework for teaching procedures can help the educator to quickly assess the learner's knowledge and allow for teaching at all levels. First, let's begin by defining skills in general and procedural skills in particular. A skill is a task which is learned. It is not innate to the learner. Furthermore, skills can be broken down into steps, and they require practice for improvement. That practice may be a particular step as well as the skill overall. Skills also have a specific measurable goal or outcome. Procedural skills can be defined as a subset of skills in general. They're defined as a mental and motor activity required to execute a manual task. These can also be termed a psychomotor skill or a technical skill. Clinical skills require the mastery of multiple cognitive and psychomotor components, and as such are often more readily taught through demonstration rather than simply description. It is important to emphasize that learning a skill involves more than just performing the skill manually. There are many other considerations, including knowledge of the procedure to be performed, communication skills. Becoming competent in a skill involves 3 main components: knowledge, communication, and performance. Knowledge. Prior to performing the procedure, the learner should be able to describe many aspects of the procedure, including why we're doing the procedure, what complications could occur as part of performing the procedure, as well as how to prevent, troubleshoot, or otherwise address them. Communication. The learner should be able to communicate this knowledge to the patient as part of the informed consent process and also be able to communicate their need for help. Performance. The learner should know the steps prior to commencement of the procedure and be able to verbalize all steps of the procedure as well as any post-procedural care. The educational theory behind teaching psychomotor skills focuses largely on the idea that skills are best learned by following a series of steps, and that through repetition of those steps with appropriate feedback, learners can best attain and retain knowledge. One of the challenges in doing this is that once an individual has become an expert in a procedure and is performing it regularly, it can be difficult for them to break down this step into smaller steps, as well as to communicate that effectively to a learner. Using a framework to teach procedural skills can help streamline the process for the busy clinician educator. In the next few slides, we will critique one older framework and introduce a newer one, which can be used by the clinician educator. In general, frameworks for procedural teaching include 3 main elements: preparation, verbalization, and practice. Preparation includes obtaining background information through reading, watching videos, as well as visualizing the procedure as demonstrated by an expert, either in person or in a recording. Verbalization includes both the verbal expression of the steps by the expert, as well as by the learner prior to actually performing the procedure. This step not only helps with retention of knowledge, but also helps the educator to identify the learner's skill level and needs. Practice. Practice should include practicing the subcomponents first, leading up to the complete performance of the skill in all of its parts. For example, a junior learner performing a laceration repair may consider subcomponents of that procedure to include site cleaning, anesthetizing, placing sutures, and tying knots. Each of these steps can be practiced individually prior to the learner completing the entire task him or herself. Feedback should be given to the learner during both the verbalization and practice stages, moving beyond see one, do one, teach one. The traditional framework for teaching procedural skills has been see one, do one, teach one. This phrase was coined in the 1890s by the surgeon Dr. Halsted at Johns Hopkins. While this method may have its benefits, particularly related to kinesthetic learners, it is an overly simplistic approach to teaching and learning procedures. Without background knowledge, seeing one is an ineffective way to learn a procedure. And in an era of appropriately increased attention to patient safety, performing a procedure on a real patient without adequate preparation would be risky and irresponsible. Finally, without confirming that a learner has mastered a procedure without error, expecting them to teach someone else can contribute to those errors being passed from learner to learner. So, what's a better alternative? Peyton's four-step approach is a newer framework that can be more easily used in the clinical setting. Peyton's four-step approach consists of demonstration, deconstruction, formulation, and performance. First, there is demonstration of the skill, followed by verbalization or deconstruction of the individual steps. For frequently performed procedures, this can be done in real time. But for infrequently performed procedures, such as transverse pacing, cricothyrotomy, thoracotomy, this can also be done via pre-recorded videos. Prior to performing the procedure, the learner must then verbalize the steps of the procedure. This is the formulation step. Finally, the learner demonstrates the skill while also verbalizing each step. This is the performance stage. This approach can be useful for all levels of learner, as the instructor can start at any of the levels based on the learner's prior knowledge. For example, you may do steps 1 and 2 on day 1 of a rotation, and then have a learner advance to steps 3 and 4 as the rotation moves on. For an advanced learner, such as a senior resident, the clinician may start at the formulation step to ensure they have sufficient knowledge before moving on to the performance step. For a more junior learner, such as a medical student, the clinician may only do steps at 1 and 2 with the learner, and then perform the procedure him or herself. This framework is particularly helpful in a busy setting without longitudinal access to learners. If a clinician is precepting an individual only once or twice, it may be challenging to trust their skill level. Using this approach can allow the clinician to quickly assess the learner's knowledge level prior to going to the bedside. Another strategy is the learner checklist. Procedural teaching technique that can be helpful to assess a learner's level of skill is the learner's checklist. This list is an overview of the information the learner must obtain prior to physically doing the procedure. This can be used as a checklist prior to the procedure to ensure they are adequately prepared. During the cognitive or conceptualization phase of the framework, the learner must be able to verbalize these components of the procedure. While the learner may be eager to jump into the technique component, each of these elements is a key part of learning procedures, and thus the learner should be able to verbalize these clearly. An example of checklist could include the indications. Why is the procedure being done? Contraindications. Are there any contraindications to this procedure in general, or to this procedure on this specific patient? Materials. What materials are needed to safely perform this procedure? Informing the patient. What does the patient need to know? What would informed consent for this procedure look like? Technique. How is the procedure done? Complications. What problems can arise? And if they do, how will they be managed? Interpretation. How do you assess the procedure? Whether you are using Peyton's four-step approach or a learner checklist, you must use some sort of debriefing or feedback after the learner performs the task. The Pendleton framework is a type of formative feedback for the learner to help them improve. While there are lots of techniques for providing feedback to your learner, here we're focusing on Pendleton. The Pendleton framework is an easy, learner-driven way to give specific and useful feedback. You start by asking the learner to self-reflect on how the procedure went. Then you tell the learner what went well from your perspective. Again, you circle to self-reflection and ask the learner what could be done differently or improved upon next time. And follow by summarizing some pearls of what you feel may help them in the future, or any opportunities for difference or improvement that you observed. Ultimately, teaching procedural skills is a fun and interesting challenge in emergency medicine. Some take-home points are: make sure you teach the fundamentals clearly. Even the very smallest sub-steps should be included. For example, good hand washing prior to the procedure. Demonstrate clearly. The teacher should provide clear demonstrations for the learner to see. Integrate theory and practice. Learners should understand the evidence behind their actions. This can promote clinical reasoning and help with troubleshooting problems should they arise. Break the skills and procedures down into steps, small steps. Find out what the learners already know and proceed from there. Use collaborative problem solving. Allow the learners to work together towards a solution when a challenge occurs. And provide feedback, specifically feedback that is clear, constructive, and in an appropriate environment. It's time for our post-curriculum activity. Use the activity printout accompanying this module to assist with the exercise questions. Think about the last time you did a procedure with a learner present. What was the skill level of the learner? How do you know? How could you have used the learner checklist or Peyton's 4-step approach to involve the learner? Pair up with a partner and share your thoughts. Strategize a plan for teaching a procedure on your next shift.